What is going on, wonderful people? Welcome back to another explainer where we make medicine make perfect sense. Today, we're strapping in for an absolute crash course on migraine pharmacology. We're talking general pharmacology, neuropharmacology, and just the absolute chaos of the human brain. So grab your coffee, sit up straight, click that mental subscribe button in your brain, and let's get started. You know, the great Charles Dickens once wrote, "It was the season of light, it was the season of darkness, it was the spring of hope, it was the winter of despair." And honestly, nothing says winter of despair quite like staying up all night studying for a massive pharmacology final. Except, maybe, the absolute, relentless, throbbing agony of a migraine attack. I mean, if you've ever had one, you know exactly what I'm talking about. Okay, let's dive into this. What actually causes this agony in the brain? Why does a perfectly normal, productive day suddenly turn into a dark room, zero noise, please make it stop, absolute nightmare?
Well, it all starts with something I like to call the confused neuron.
Imagine your brain's neurons are usually conducting this beautiful, synchronized symphony. But during a migraine, the conductor drops his baton, the brass section goes totally wild, and everything gets incredibly painfully confused. You see, the headache isn't just pain. It's a whole sequence of vascular and functional changes. It kicks off with a spreading depression of neuronal activity in the posterior part of your cerebral hemisphere, and that's accompanied by severely reduced blood flow or hypoperfusion.
I always say what you write and write what you say. Let's watch these steps unfold. Step 1, spreading neuronal depression. Step 2, hypoperfusion, spreading forward over the cortex. Step 3, arterial vasodilation. The blood vessels open up super wide, both intracranially and extracranially. And step 4, that massive vasodilation triggers the release of nasty, pro-inflammatory neuroactive molecules right on the trigeminal nerve. We're talking substance P, neurokinin A, and calcitonin gene-related peptide, or CGRP. Basically, your confused neuron is literally bathing your cranial vessels in pain juice. All right, before we treat it, we've got to classify it. Forget those boring, dry textbook presentations you've sat through. Let's make this totally memorable. Look at how these stack up. Migraines, they're severe. Unilateral, meaning they hit one side of the head and they are pulsating. And get this, they last anywhere from 2 to 72 hours. Think about that for a second. 72 hours of throbbing pain. They come with photophobia, like turn off the lights immediately, and phonophobia, seriously stop talking, plus nausea and vomiting. Now contrast that to a tension headache. That one is bilateral, dull, feels like a tight band around your head. Or a cluster headache, unilateral, right behind the eye, excruciatingly sharp, but it only lasts 15 to 90 minutes, complete with sweating and a runny nose. The bottom line, if you have a patient vomiting in a dark room for a day and a half, you are definitely dealing with a migraine.
So we know the problem. The confused neuron caused huge vasodilation and inflammation. How do we fix it? Let's talk acute therapeutics. Enter the absolute first-line, heavy-hitting rescue medications, the Triptans. These beauties are serotonin 5-HT1B and 1D receptor agonists. If the pain is caused by arterial vasodilation, it makes perfect sense that we need to counteract it with vasoconstriction. By activating these very specific receptors, triptans clamp those vessels right back down and stop the release of those painful neuropeptides. Vasoconstriction for the absolute win. Notice the magic suffix highlighted there, Triptan. If a drug ends in triptan, boom, it's an abortive migraine medication. Sumatriptan was the first, the classic prototype. You can give it orally, subcutaneously, or intranasally. Now put your clinical hat on for a second. If you have a patient who is literally vomiting their guts out from a migraine, are you going to hand them an oral pill? No way. They'll just throw it right back up. So an intranasal triptan, like Sumatriptan, is a brilliant pharmacological workaround. And if you need incredibly long-lasting relief, Photophobia is your absolute champion, with a half-life of over 24 hours. But wait, stop right there. Every medication has side effects. There are no perfect solutions in pharmacology, only trade-offs. Remember, triptans are vasoconstrictors. So what's the adverse effect? Chest pain and elevated blood pressure. You are actively constricting blood vessels. Therefore, you absolutely must perform a cardiac evaluation before giving triptans to a patient with any risk factors for coronary artery disease.
Now, what did we use before we had triptans? Let's look at the ergot alkaloids.
Before triptans, we relied on this old-school, complex, heavy machinery derived from, get this, a terrifying fungus that grows on rye plants called Claviceps purpura. These are the ergots. To compare them, triptans are like a sniper rifle. They are highly selective for those 5-HT1B and 1D receptors. Ergot alkaloids, like ergotamine and dihydroergotamine, they are basically a shotgun. Their action is totally wild, binding to 5-HT1, alpha, and dopamine receptors all at once. Because of this messy binding, ergots can cause dependence, rebound headaches, and terrible nausea, so we usually save them strictly for severe, intractable cases.
Which brings us to a crucial point. You have to know when absolutely not to use them. These are heavy vasoconstrictors. So what are the contraindications? Angina, peripheral vascular disease, and pregnancy. Ergot alkaloids are incredibly potent uterotonics. They will cause the uterus to forcefully contract, leading to fetal distress and miscarriage. You never, ever give these to a pregnant patient, period. In fact, let's be super clear. If I ever hear that you gave a potent vasoconstrictor like ergotamine to a patient with angina or peripheral vascular disease, I will personally find you and smack your gluteus maximus. That is a massive doofus mistake. You are constricting vessels that are already diseased and narrowed. Just don't do it.
Okay, but what if your patient is suffering from several severe attacks every single month? You can't just keep rescuing them over and over. You need prevention.
Again, say what you write and write what you say. To stop the confused neuron before it even starts misfiring, we use an incredible pharmacological arsenal for prophylaxis. Number 1, beta blockers, like propranolol. Number 2, calcium channel blockers, like verapamil. Number 3, tricyclic antidepressants, like amitriptyline. Number 4, anticonvulsants, like divalproex and topiramate. With these, we are literally calming the brain down, stabilizing the cell membranes, and altering vascular tone so that spreading depression just never happens.
And honestly, this brings us to the beautiful, delicate balance of autonomic pharmacology. Fixing a migraine isn't just about killing pain. It requires a masterful balancing act of targeted vasoconstriction, neurotransmitter manipulation, and stabilizing ion channels, all without triggering massive catastrophic side effects in the heart or the rest of the body. It's truly amazing. Which leaves us with this final, kind of mind-blowing thought. If a tiny tweak to a single 5-HT receptor can either cure an agonizing 3-day headache or accidentally cause dangerous cardiac ischemia, what other hidden, terrifying powers do our confused neurons hold? Think about that as you tackle your next big pharmacology chapter. Keep learning, keep studying, and I will see you in the next explainer.